There we go. So high degree scoliosis. That is basically what the system has been designed for in the early years. So we talked about the history in brief yesterday a bit on a short term, but basically, or the basic starting point for the system was actually scoliosis and how we could be able to reduce radiation exposure in a scoliosis patient just for the purpose of posture tracking. And that's, well, what the first application point was when the system entered the market back in '96. What can you measure? Well, you can measure leg length discrepancy or a scoliosis and nothing else. So that was the unique selling point of the DIERS for metric back in '96, and over the years, gladfully, it grew, and we now have many more application points, but that was the very starting point. And talking about the scoliosis, so I will not go through this one by one, left to right or something, so we will jump a bit around, so that gives a bit, adds a bit of a dynamics. Of course, what do we have on a scoliosis? We will have a lateral deviation of the spine. So the lateral deviation, that will be, for example, this right convexity of the spinous, the vertebral corpus. This is completely correlated to the lateral deviation that we can see here in the English translation. That's more the technical engineering wording. It is the apical deviation that we see in the table. And from the orientation of the graph, you will always see where you have your largest excursion and where excursion starts anyway. So if we now see that maybe at the level of L5 and L4, we still have a rather straight lateral deviation, and then it will start. It is another meaning, maybe also on a muscular interpretation, as if we have an entire lumbar spine being straight and then the thoracic spine is moving to the deviation. So that's how you can simply also look at it on a subjective way in a first hand. So that's always depending on you, how you want to look at the data. So, but from my perspective, from my approach towards the measurements, it's always first subjective, and then I go to some parameters and some quantification. Basically, every measurement that you do, no matter if it's static or dynamic, whether it's just spine or there is a leg axis included or a pressure plate or whatever, it's always a subjective information that you need to add to this. The subjective information is reflecting your very own expertise, and this is always a very important keystone to the diagnostics and to the interpretation. So the system is not taking away something from you, it should add to your competences. And once you will be able to bring your own expertise to the diagnostics, to the interpretation, and find some parameter constellations that are really matching what your expertise is already telling you. So this is building trust into the system, and this is also building trust or compliance to the patient, because the patient understands this and feels this, and well, appreciates this if you're familiar with that system also from that subjective way. So first thing would always be, what is my own clinical approach? So I am more the muscle function related type of person. So that's how my approach towards the results is. And I always try to find a bit of a reason how to connect a deviation like this to a muscular situation, because the muscles need to align somewhere around it, so they are responsible for a deviation that we see here. So the bone itself will not grow like this, but there is always some soft tissue that is moving along with it, or maybe even pulling it. So that's my approach, which is not a holistic approach, I know that, but then every one of you has an own approach, and this is no wrong approach at all. So because it's just another perspective to that same thing, and if you're experienced in that very profession, that's all you need to get jump started into that diagnostics, because this is what you add to the system anyway. So As we're talking for the lateral deviation, a spine would never be able to only do a monoplanar deviation to one side only, especially at this extent. We will always have the tendency to rotate as well. So if this is my vertebral body with the spinous process pointing back, so a segment will never jump to the left or to the right, but it always do this movement. So will always be a deviation and a rotation at the same time. So measuring from the back, that will see the spinous process rotating to the other side. So that means if my lateral deviation, and we can see this here as well, apparently the x-axis is not wide enough, so that's why it's a bit straight here, but still we have a lateral deviation to the right, which connects to a surface rotation to the left. That means a surface rotation, we measure the surface, so that's why we relate to it, is always showing us the rotation of the symmetry line, which normally should be the attachment point for the spinous process. So having the symmetry line rotating to the left will also indicate that our spinous process is rotating to the left. And you can clearly see, so where our lateral deviation goes out max, then we have the counter rotation of the surface rotation at the same level. So that's a regular finding. Talking about the rotation, we had a brief discussion about this yesterday. What if we have bony deformities? So like maybe a spinous process deformed and maybe bent to the side. So of course, this is something that we will not be able to fully show in the spine model. So our spinous processes will always be straight. So they will always be pointing towards the symmetry line. Still, the symmetry is something that is global. So that is showing the global alignment of the spine itself. So not only the spinous process. So if my spinous process is bent, still the surface on top of the original position of the spinous process will show a symmetry point that points towards the center of the vertebra. So therefore, we should be able to fully rely on the symmetry calculation, even if the anatomic model is not showing it very correctly in that case. On the other hand, there's always an on the other hand, of course, we will have higher degree scoliosis, which the higher the value of a Cobb's angle will be, the more our symmetry model will not work out anymore. So talking about a Cobb's angle of 60, maybe 70 degrees. So that's something that the system will not detect at the same accuracy that it could when we talk about a Cobb's angle of only 20 degrees. Because the patient is really rotating that much that we would never be able to calculate a spinal alignment just by the symmetry, because the symmetry is not there anymore. So the symmetry got lost, and we have such a strong rotation, such a strong lateral deviation that parts of the surface that we would need to measure to calculate the correct symmetry point are just bent away out of the stripe projection. So that's something that would be giving you a bit of an impairment when we go to a high degree scoliosis. So the way to work around this would always be to add some additional markers throughout the alignment of the spinous process line at the regions where the symmetry got lost. So I will show you another sample in a short span, and we can see how the things are changing if we're using some additional markers, if we're able to spot the correct spot on the vertebral alignment. One important part of the surface rotation, we calculate this always in relation to the pelvis. So that is why your surface rotation will always end at the zero position at the lower end. So that is always given. So if I'm standing there with my 5 degrees pelvis rotation to the left, of course, my point of view will counter-rotate. I want to look straight again. So somewhere in my spinal alignment, I will derotate and bring myself back to the regular horizontal alignment. So if this is showing, if we would show that, well, that lower end will just deviate to the left in my case, and then I will see only the compensation and segments that are responsible for proper rotation correction will be shown at the 0 level. But those are the segments that normally have the highest load in muscular activation in order to realign the entire spinal rotation. So therefore we will not be able to spot them. So that's why we correlate to the 0 here. So then we can spot the points of highest deviation as well as some crossings around the 0, which will always be set in relation to the pelvis in order to get an information on those segments who have the highest muscular load. No matter whether the pelvis is rotated 5 degrees to the left, 5 degrees to the right, or maybe 10 degrees to the left. So that should never be a problem for you. So sometimes it's also, on the treadmill, it's always a bit hard to understand whether the patient is really standing perpendicularly to the system. So then you might have a slightly rotated position of the patient towards the cameras. So then we would be able to just recalculate and just derotate the pelvis and rotate the entire thing. So if I'm standing like this and I'm turning against it, the entire finding of the measurement would simply turn this like this so that my pelvis is perpendicular to the surface, to that user interface, and I can see where I'm performing some rotation correction. And that is the level where I can take a deeper look into muscular symmetries, and a very important part is something that we will never be able to measure, but still we can get a bit of a feeling on this, would be the upper outcome of the surface rotation. As you can see here, it is slightly rotated, which, well, is some muscular constraint, which could be some neck muscle which is already in asymmetry. And if we always consider that the eye line is put to the horizontal into perpendicular position, then this one could be either compensation for that if my pelvis is highly rotated, or it is simply out of position if maybe some rigidity in the thoracic spine is not allowing for some proper compensation to the 0 again. So if this one is highly rotated, I would give you one tip, and this one is hidden in the transversal plane tap. So that's where you would move in then in the next step. So the transversal plane tap is something that is a bit complex, so know whether you have already worked with it, but if if you move your mouse over the stripe projection, you can simply roll your mouse wheel in order to reach a certain desired segment area. And on the lower end, you can see that cut. This one, that is the surface cut. So that is more like the MRI style cut of that stripe projection. So currently we are looking from feet to head, with the patient laying prone. You will have your red superficial line, so that is the surface of that region where we're in. Then you have your segment, which is just pointing up below it. Shows quite well how we calculate from the symmetry point to the orientation of the spinous process. And we have a yellow line. This is the pelvis line, which is at 0 currently. Let me see, what do we have? So we have some pelvis rotation. That's quite good. Now, that is the pelvis correction. So every rotation that we show also in these cuts will be related to the pelvis. So the pelvis will always be 0 at the start. Now you have one button here, which you can choose to remove the pelvis correction and look at the sample standing in its environment. So we are not relating to anything. So now this is how your patient is standing in front of you. You would see that the right innominate is rotating forward, the left backward, and then you see the spine arranging around it in order to get the eyes straight again, even in such a high degree scoliosis patient. So the eyes will always be straight. So if I'm standing like this, so my head will not tilt like that, but it will always be like that, so the eyes get straight again. So that's what we can always assume. Now, as we have some rotation here, now we can scroll up to the cervical spine, let's say the C7 spot. And we can see there is a very large rotation here, so it even adds to the corrected rotation value itself. So whatever we can see as a pelvis rotation is also represented by the C7 rotation. So what this is giving you, so if C7 in environmental orientation without any pelvis correction is standing in rotation, that means that upper cervical parts need to counter-rotate in order to set the eyes straight perpendicularly. So that means if you are dealing with patients that are suffering from chronic headache, dizziness, some cranial, other cranial complaints, that could give you an information about some muscular asymmetry that is happening in the upper thoracic spine, the upper cervical spine, so that we are not really able to display in the model, but still we can get an estimation on the muscular status in that region anyway. On the other hand, if we remove the pelvis correction and we scroll up to the C7 and we see a perfect zero position of the spinous process, that would guide our focus a bit away from the head and then more towards the thoracic spine where that rotation is actually happening. So that would be the differential diagnostics, if we want to call it like that. So remove the pelvis correction. You can see the pelvis rotation value here as well. So I don't know whether this is displayed a bit too small, but then I can also use the magnifier here maybe. So here we go. So this is the pelvis correction is at 5 degrees to the left, pelvis rotation. So that means, well, so I talked about it, so 5 degrees to the left, so that's what I can perfectly show. So that's basically it. Patient standing like this. So the ASIS looking towards 11 o'clock. And if that pelvis rotation is there, always try to remove the pelvis correction one time and scroll up to the C7, especially if you have some patients that are dealing with some cranial symptoms. Now, as for the frontal projection, so we come back to the frontal projection here, even if it's not very impressive in her case, but still, you can see that dashed red line that is pointing between C7 and the dimple middle. Now, that line is defining actually the degree of lateral deviation. And the lower end of that line and its distance to the global zero line will indicate the coronal imbalance. So this is the difference between one and the other. So move this down a bit, so otherwise you will hear me breathing. That means if I have my shirt like this, standing more or less upright, and my spine is deviating. So this is the lateral deviation. So everything that is going from so let's see, like this. Everything is coming just from the line here and deviating there. That's the quantification of a lateral deviation. If I'm standing like this, so this is the straight line connecting C7 and the pelvis. Now, if my spine is straight in this, I will have a coronal imbalance, but no lateral deviation if it's just running along this. Only what is really deviating from that straight line between the pelvis and C7 will be measured as a lateral deviation. So we are free from that pelvic shift position or anything in order to quantify in a neutral way. Again, you will never have to deal with something on a scoliosis treatment if maybe some patient is standing in a shift, another doesn't, so that's unimportant for the lateral deviation. I think during the cases we will see some more pronounced coronal imbalance. Actually, the coronal imbalance is a very good point to look into the dynamic profile already. A coronal imbalance normally is the key parameter if you want to quantify a Trendelenburg sign or a Duchenne sign. So if I'm moving like this and shifting my pelvis to the side, so then I'm performing a coronal imbalance. So it's just moving the plumb line away from my pelvis, and that is a coronal imbalance. In that case, to the contralateral, so the plumb line is just deviating from the stance leg, away from the stance leg. Or we go for a Duchenne sign, so that will be the very same thing, but the coronal balance goes ipsilaterally towards the standing leg. That is the key quantifier. So the only thing is, that's another lookout to the dynamic part, we need to talk about the timing. When does it happen? So on a static posture, it might already be a result of, well, a well-grown compensation into a Trendelenburg or a Duchenne sign, which then comes out perfectly well already in the postural system. But let's get back to the coronal balance if we see one, because this one is not really impressive because it's just a small deviation. What do we have as a value? It's 16 millimeters to the right, so that is the distance that we have here, which is already not that low. So you can see it better here actually. So then you can see the plumb line deviating to the right. That's the 16 millimeters to the right. And the distance between the dimple middle and that plumb line, that will be your coronal imbalance. So it's...
Maybe you can enlarge.
Which one?
The spine model.
The spine model? Let's see. Can do that, of course. Big enough? Now we can see it. That's it. So these are the 16 millimeters of a coronal imbalance, which could already be meaningful, but given the fact that we have a high degree scoliosis, maybe not that key parameter that we would deal with. Now, sticking once more with the scoliosis, we also need to talk about the scoliosis angle. So see, I jump a bit around, but I try to keep within a topic and then move to the next one. I think that makes it a bit more vivid. The scoliosis angle has been added to the system after the evaluation of the system. Of course, there are many studies about, some correlations with X-rays, MRIs. I think even there's one with a CT scan. EOS systems have been compared with a formetric, and all came out quite well, and all did perform some correlation studies, which encouraged us to keep on. But then the scoliosis angle was actually a demand from the market, especially in scoliosis care, I suppose. I'm not sure that it was before my time at DIERS, but still, of course, we would be able to calculate a COP-related, similar COP angle like we do it in an X-ray, just from the spine model out of a formetric scan. So that's no big deal because the principles are clear. We need the segments of the highest lateral deviation or the highest lateral bending, where we add the tangent. We have somewhere a counterbending, and that is giving us the angle, which in her case would be 68 degrees. But there is one very flaw in this, and that's something that, especially if you are in scoliosis care, so that's really something that you always need to understand. So this is always a value that you need to somehow moderate. You need to explain to the patient, because we are considering, well, the anatomic model of the spine model, do we? So then on high degree scoliosis, you deal with bony deformities, maybe with a spinous process bent over, maybe with some end plate just crushed in a bit or deformed a bit. So then you will have deformations in a morphological way that we will never be able to cover with the scan from the outside. So where we are touching our tangents will always be related to the best anatomic model that we can get out of that postural profile. So then we won't have those bony deformities scanned as an X-ray can do this. So therefore, the starting point of a scoliosis diagnosis will always be an X-ray. So there's no way around it. So it's obligatory, and you need to define the corpse angle. So this is well known. And normally, if we talk about scoliosis, then we already are starting into an entire universe of therapies, doctors, of physios, of parents, of the children themselves. They all learn to know about the scoliosis with the corpse angle. And now we measure the DIERS and we get a scoliosis angle, which apparently is calculated in a very similar way like on an X-ray. Why is it then 68 degrees if my corpse angle was only 60? So that is basically what you always need to explain to the patient. Well, we have a model of the morphological spine. This is what we're based, where our calculations are based on. We never see the actual real morphology, so therefore, of course, the value will be different. And of course, we still would be able to work with the scoliosis angle in the long run if we had set a correlation once. So if my patient comes in with a corpse angle of 60 degrees, we measure on the DIERS 68, so then we know about this difference of 8 degrees, and once we are performing another measurement on the DIERS, we know about the early 8 degrees and we can apply them in the next scan as well. So then, right, let's see. So now we haven't talked about the sagittal profile overall, so then that's something we definitely need to consider. So if talking about, well, the sagittal profile, of course we can talk about kyphosis and orthosis and the general parameters, of course. So in that case, we can already see, can I enlarge this a bit? Not sure that I can. Will not be that bigger, but at least we have a focus point. So the lateral projection would be on the left-hand side of the initial page. Generally, no matter which measurement we do, when results page loads, the very first page is normally the first one of each modality that I can spend up to 100% of my time just diagnosing. So other tabs that are right from that are always to be considered as additional information if I need more in-depth insight into the profile that I want to focus on. So we went to the transverse plane once we needed some more information about the rotation and the profile of the rotation. So we have a tab for the sagittal plane, which we will load if we need some more insight into the sagittal plane deformity. And or the posture type, the same, so also more related to the sagittal. But in the very first hand, it's always the very first tab that you were dealing with, and the one that I would always consider to use also in front of a patient, because every more detail that you add, your patient will hardly be able to follow along. But for you as a clinician, that could be a very good point in getting a bit more detail into that information that you already shared with your patient. So what do we see here? So we have two lines, which is the green line and the blue line. So the classical representation, so it has been there from the start. The green line is the surface line, so that is basically the symmetry line. So the line that makes two symmetric parts out of the back profile of the patient. The blue line, let's see, so let's turn this sidewards so we can actually follow along this. Whoop. There we go. Maybe I remove the skin here, so because then it's easier to understand. Zoop. Ah, wrong way around. There we go. So there we also have the green line, which is on the surface, and the blue line, which is crossing the centers of the vertebral corpus, the vertebral bodies. So this is what we see in the graph there. As I already stated in the scoliosis angle, the morphological model is always a bit tricky to understand and tricky to represent also the actual bony alignment of the patient, the bony shape of the patient. Therefore, my recommendation is clear that we should not use the blue line that much. Every information that we get for the sagittal profile is related to the green line. So if I'm moving into a subjective interpretation of that shape, which we could do quite well, so we can see that we have a rather long kyphosis, we have a rather high lordosis angle, we have a sway back position of the patient, so that would be the basic information that we can take out of the sagittal profile here. I would always go with the green line instead of the blue one. So with this we have a kyphosis angle, which in his case, let's see, so what do we have? I will translate it, it's easier. I think it's 54 degrees of a kyphosis. So even if that is a very extended hyperlordosis, we also see a very large degree of a kyphosis as well. But then the lordosis angle ranges up to 71 degrees. Now this is normally the point, sagittal profile. In my regular trainings, I start from left to right, and I will just go one by one in order to explain. And so the kyphosis and lordosis will always be the very first parameters that I explain to the clients. And normally it's always the very first situation, and then the very first question is always, but okay, now we have those values, what are the norm values for this? So there are some norm values, but they also need to be used with care. So because if we do a scan of all of us, every one of you will have some deviation that goes out of the norm at a certain extent. We have a pelvic obliquity here, we will have a lateral deviation there, maybe kyphosis here, and that's something that every one of us will show some deviations of the norm. This is not indicating any diagnosis by default. So therefore, we could tell that a kyphosis angle should range up to 50 degrees. So 54 is a bit at the upper end. We could say a lordosis angle is at approximately 30 to 35 degrees on a male patient, and maybe up to 40 degrees on a female patient. So that would be what we can find in literature, and it's quite well applicable. Still, we haven't introduced this that much on the first hand, in the first page of the overview. So therefore, we are still in the need of adding some subjective interpretation to what we see as a results display. So the parameters and the extent of the parameters are always just the expression of it, but they come together with, well, my general subjective impression of the patient, maybe some other diagnostic findings that I already have from my patient, maybe the complaints of the patient, and that all together gives us well, a perfect picture. And if my sagittal values fit into that, so then I can take those values and say, okay, look, this lordosis is really high, so we should do something about it. So if my patient is has complaints in a totally different part of his body, maybe that would not be the very first parameter to address. At a lordosis of 70 degrees, maybe I would at least give some preventive information. That's so look, now you're young, maybe you should do something about it, but maybe it's not that primary focus point in therapy, so then I would not put it to the front end of my interpretation and to my explanation towards the patient. So that's always a bit an entry point to whatever we measure, and to interpret this is always why is my patient here? So what is bringing that patient to my clinic, and what complaints does he report from? How is daily life of a patient? What are daily life activities? Is there any activity at all? Is it just seated position with maybe a 9-to-5 job and then going to the sofa at home? That's some information that we need to put into, and that can really give us a bit more of a quality in also filtering the data and looking for some relevant data in some cases. So in this case, I don't have any clue about what the complaints of this patient were. So he was, I think, 7 years old when he was measured, so then I assumed that it was just a preventive screening where we saw, oh, look this, so maybe some doctor said, so that is a bit of a hyperlordosis, maybe we should have a measurement and see how large it is actually. But the basic therapeutic idea, I think, was already set before the measurement. So that was just for documentation, I think. So, but anyway, we will talk about this sagittal profile as it is already loaded. Now, kyphosis and lordosis are a very rough interpretation of the sagittal profile because the measurement points are are positioned in a large distance. So that large distance we will see in the sagittal plane tab. We see, so then I would need my magnifier again. So at least it's a bit larger here, and we can talk about what we see here. Now, the general graph is still the same, so we are not talking about any difference with regards to the first page, but we have added some information here which are not present in the very first tab. So you see all of the gray tangents, which are then also coming together with some measurement points. We are talking about the kyphosis apex and lordosis apex, which are indicated as Ka and La. Now, the kyphosis apex should be located somewhere around about T8. If it's T7, never mind, so that's all fine. If it's T9, maybe a bit low, but still okay. But that should be the range in which the kyphosis apex should be located. If we talk about lordosis apex, we normally estimate this at the level of L2. In between, our spine is shaped as a double S. So parts of the double S we are able to measure. So we will have some turning points here. So we have one turning point up there that is changing from the cervical lordosis towards the thoracic kyphosis. We have a turning point here that is turning from a thoracic kyphosis towards the lumbar lordosis. And we have a lower turning point which then turns the lordosis to a kyphosis in the sacral part of the spinal alignment. That would be the mathematical interpretation, and what is defining those points is actually pure mathematics, normally some mathematical concept that you learn in the 8th grade. And from a clinical point of view, we are talking about the intersection points. So this is the cervico-thoracic junction, the individual cervico-thoracic junction of that patient and the position it is in. So we normally expect this to be somewhere around about C7, sometimes it's C7, sometimes it's T1. We move down to the ITL, which is then the thoracolumbar junction, which we estimate to have it located at T12. And we have the lumbosacral junction, which is normally below the DM or at the DM level, so the dimple middle. Now, just from the positioning of those points, we can already judge in a subjective way on the sagittal profile itself. Now, if we just move over here a bit more to the right, we can see that our cervicothoracic junction is right where it said it would be, so somewhere at T1. We have the kyphosis apex, which is way higher, so we talk about T5 here. Still, our thoracolumbar junction is at T12. And then the lumbosacral junction, so it's not magnified here, but it's at DM. So as for the location of the points, This is rather well distributed. Still, the kyphosis apex is rather high, but that's normal. If I have a sway back position like this, of course, then my maximum convex point will just move upwards. By this, we normally expect to have a relation in length between the cervical-thoracic junction and a thoracolumbar junction, which is at approximately 2:1 between cervical-thoracic and thoracolumbar and lumbosacral. If your patient, so again, highly subjective, so we are not talking about any measured value. So we try to calculate this, but so there's also some parameter in the background that would provide you with some calculation of this ratio, but still, we are talking about the subjective impression. And if your patient moves into a relation of 3:1, so a very long kyphosis, then it doesn't need a higher lordosis angle to produce higher loads in the lumbar spine, because my lumbar curvature will be distributed over less segments.